Welcome to The Explainer. Today, we're tackling one of the most common and, frankly, most feared injuries in all of sports, the ACL tear. We're going to walk you through the entire patient journey, from that split second on the field all the way to what life looks like years down the road.
All right, so here's our game plan. We'll start with what's actually happening inside the knee when it tears. Then we'll get into the diagnosis and that big question, why me? From there, we'll look at the treatment choices, map out the long comeback trail of rehab, and finally explore the new normal, life after injury, and how we might prevent it in the first place.
Okay, let's start right at the beginning. Picture that moment on the field or the court. In that split second, what is actually going on inside the knee to cause such a devastating injury?
You know, for so many athletes, this whole thing begins with a sound you never want to hear. It's this loud, distinct, and honestly sickening pop. And that's not just a feeling. People nearby can sometimes hear it. That is the literal sound of the ligaments snapping.
So, what is this thing, the ACL? Well, it's one of the 4 big ligaments in your knee, and it's basically a super tough band of tissue only about as long as your thumb. But its job is massive. It acts like a brake, preventing your shin bone from sliding out in front of your thigh bone. It's absolutely crucial for stability during all those quick cuts, pivots, and sudden stops that define pretty much every sport.
And right after that pop, a whole cascade of symptoms hits, and it hits fast. The knee just blows up, swelling almost instantly. And get this, that's not just fluid, that is blood from the torn ligament pouring into the joint. Combine that with this awful feeling of the knee just giving out, buckling underneath you, and you know right away, this isn't just a sprain, this is something much, much worse.
So, you're off the field, you're with the doctors. They suspect an ACL tear. Now what? The next step is confirming it for sure. Let's dig into how they do that, and then explore that question every injured athlete asks. Why me? Why are some people so much more prone to this?
Well, getting the diagnosis is usually a 3-step process. First, the doctor just wants to hear your story. What happened? Did you plant? Did you twist? Did you hear that pop? Then comes the physical exam, where they'll perform special tests, like the Lachman test, to physically feel for that looseness in the knee. But the final verdict, the gold standard, is almost always an MRI. That's what lets them see right inside and get a crystal clear picture of the torn ligament. Now, this right here is something that blows a lot of people's minds. We all picture a huge football tackle, right? Some massive collision. But look at this. The vast majority, a whopping 70% of ACL tears, are non-contact injuries. That means it wasn't another player who did it to you. It was your own body's movement, a sudden stop, an awkward landing, a pivot gone wrong. When we dig into who is getting injured, the data is just stark. In the exact same sports, doing the exact same movements, female athletes are anywhere from 2 to 8 times more likely to tear their ACL than male athletes. That is a massive, massive difference.
So what's going on? Why is there such a huge gap? Well, it's not a simple answer. It's this really complex mix of factors. There are anatomical differences, like a wider pelvis that can change the angle of force on the knee. There are hormonal factors. Estrogen might actually make ligaments a little bit looser. And there are neuromuscular differences, which is just a fancy way of saying how our brains tell our muscles to fire when we jump and land.
Okay, so the diagnosis is confirmed. You have a torn ACL. Now you arrive at a huge fork in the road, and this is a really big deal because there is no single right answer for everyone. You have 2 very different paths to choose from.
And that choice really boils down to you, your body, your lifestyle, and your goals. For someone who's less active, maybe doesn't play cutting and pivoting sports, building up the muscles around the knee to compensate might be totally fine. But for an athlete who needs to get back to a high-demand sport, surgical reconstruction is almost always the standard path to restore that crucial stability.
Now, let's be clear. The non-surgical route is not the easy way out. It is an intensive physical therapy journey. After you get the initial pain and swelling under control, you're looking at a tough 3 to 6 month program designed to make your leg muscles so strong they can do the job the ACL used to do. And for the right person, it can be successful, with about a 60 to 80% success rate for non-pivoting activities.
Okay, but if you do go the surgery route, the decisions don't stop there. The next big choice is, what do we use to build the new ligament? And this table really shows you the trade-offs. You can use your own patellar tendon, which is super strong but has a risk of future knee pain. You could use your hamstring tendon, which hurts less to take but might stretch out a bit more over time. Or you can use an allograft from a cadaver, which means no extra pain for you, but it comes with a significantly higher failure rate.
It is so important to understand this. The surgery is not the finish line, not even close. It is day 1. It's the starting line of what is, for most people, a 9 to 12-month journey of painstaking rehabilitation. And while this surgery is generally very safe, it's still a major operation with risks. The most common problem is the knee getting really stiff, which happens to about 1 in 10 people. You also have to worry about things like blood clots. And of course, the biggest fear of all, that the new graft just doesn't take and it fails.
The rehab process itself is incredibly structured. You can't just circle a date on the calendar and say, I'll be back by then. It doesn't work that way. It's all based on hitting specific goals. You literally have to earn your way to the next phase by proving your knee has the range of motion, the strength, and the control it needs. It's a step-by-step process.
Those first 6 weeks after surgery are absolutely critical. They set the foundation for everything that comes after. The whole game is about protecting that brand new ligament while gently getting basic function back. And the number one goal, above all else, is getting the knee perfectly straight and waking up that quad muscle, which has a tendency to just shut down after surgery. As you get stronger, you start to systematically rebuild everything you lost: your power, your agility, and just as important, your confidence. You'll slowly progress from jogging in a straight line to jumping and landing to cutting drills. And that final green light to play again, it's not based on time. It's based on cold, hard data. You have to pass a series of strength and hop tests, proving your surgical leg is at least 90% as good as your other one.
So, after all that, after the pop, the surgery, the months and months of rehab, you're finally back. But what does life look like years down the road? Is everything truly back to normal?
Well, the long-term reality is complicated. The good news is really good. The vast majority of people, 80 to 90%, get back to doing the activities they love. But here's the sobering side. About half of them will develop arthritis in that knee within 10 to 15 years. And maybe even scarier, the risk tearing it again is alarmingly high, especially for athletes under 25.
But I want to end on what might be the most powerful number in this entire explainer. Look at this. We now know, with tons of research to back it up, that specific training programs that teach athletes how to land and cut properly, can reduce the rate of these injuries by 50 to 70%. I mean, that is a staggering, game-changing number.
And that brings us to our final thought. Our surgical techniques have become incredible. We're amazing at fixing the ACL. And yet, the injury rates keep climbing. We have the tools, we know prevention is profoundly effective, but it's just not being implemented everywhere. So it really makes you wonder, what's the missing link? Why are we not focusing more on preventing the injury from ever happening at all?